Welcome to Direct Supply's Continuing Education webinar series. Direct Supply offers monthly webinars on a variety of topics throughout the year. The topic for today is CMS Emergency Preparation, What Have We Learned? My name is Savannah Ocasio, and I will be facilitating today's meeting. Please note, the information contained in this presentation is intended to provide general information but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. Today's webinar will be presented by Ray Miller. Ray is the Director of Risk and Safety Solutions for Direct Supply. He guides the development and implementation of resident and employee safety, risk management, and loss prevention programs. Ray leads the Direct Supply Loss Prevention Forum, a network of risk and safety professionals in the senior living industry. Ray also provides education, training, and insight for senior living providers at all levels within a long-term care community. He is a regular speaker at many national and state long-term care corporations and conventions. And now please welcome Ray.
Hello, everybody. Appreciate the fact that you're here with us. You had lots of other things you could be doing, and I'm grateful you're taking the time for this. We hope it'll be of use to you. You can see that little slide there in the background. I've used it many, many times. And I had somebody in a meeting, and I think it was in Tulsa, Oklahoma, and we were doing emergency and disaster preparedness. And he got there a little bit early, and the slide was up, and he went down through it, and he says, Ray, that is a really good outline of the requirements. So, take a minute or two. You'll have access to this PowerPoint as a PDF, and so you'll be able to pull it down and use it for your own purposes. Well, let's talk about CMS a little bit. They rolled this thing out, and I think they did it to us, if you would. And so I went out to their website, curiosity, to take a look at when they last updated it. Well, it hasn't been touched since November 1st of last year. And yet we've been learning new things, interpretations, applications, some guidance from outside sources, and yet you're not necessarily going to be able to find the most recent. It's worth going through their Q&A responses to things, but those haven't been updated either. But still, there's a lot of good material out there, so get used to this web page, and it's worth going out to. They did make kind of an adjustment on their focus, and we're used to these same ones we've talked about in the past, and we'll keep talking about them for a while. But now they've really established the 4 core elements. No surprise there either. When you look at the standby power systems and the integrated healthcare systems, there's a lot going on in those areas. It's so facility-specific, so community-specific that they are important. You have to comply with the requirements. But those first 4 are ones that you're going to get popped for if you don't have good programs, good policies, and procedures. I kind of like this quote, and it's by a Max Mayfield. He's actually the director of the National Hurricane Center. And he said, preparation through education is less costly than learning through tragedy. So I kind of adopted a little bit. Partly, that's not my picture. That's my younger brother's picture. And my version of it is preparation through education is less costly than learning during a survey. Oh, man, don't we all know that? But you just don't know what their personal interpretations are going to be. And that's kind of our challenge. So I stuck this. This is a slide that's a little different from this same presentation we did last week, because I still want to ask this question. You can probably see what's in the background of that picture. Emergency or disaster? Part of my response is, well, it depends on whose yard it is, whose camera it is, all of that sort of stuff. For somebody, it could be a disaster somewhere. Well, this is actually Sue Levin's front yard that she's taking this picture from. And Sue is one of those folks that works on the TELS team. She also serves on the Life Safety Code Committee for ACA, as well as the Emergency and Disaster Preparedness Committee for ACA. And she's been very helpful in the preparation of these slides, especially when it gets to the data. So with that, here's what we're going to get used to. We're going to look at some data, okay? We're going to look at some ideas and some thoughts, and the data came from the CMS Health Inspection Database, and it's the first 6 months of the year of the 2018, and these are the kind of numbers we're seeing. Now, I've sorted them based on the total count, and that's column 2, and it's kind of a small screen, but the testing and training, conduct testing and exercises tag 390039 had 460. That's the highest percentage, but that's actually over 10% of the total tags issued in that first 6 months came from that one. Well, it was helpful to me when I could start doing a visual sort on some of those. And so I added some yellow, and that's the testing and the training. So there's 3 tags there for testing and training. The policies and procedures are the blue ones. And then there's a little group of red ones, sort of independent. There's only 4 of those. But then communications became a big deal, too. And if you look at the second column in that small insert, the policies and procedures had 185 total tags, and it was 43%, almost half of them in that one. You can see the communications. Well, what I've also done, though, is add one more column out there, and it was just a curiosity piece for me. I was curious as to how many citations were issued per tag, and so all I did was I took the 1875 divided by 12, so it's 156, 130, and then you get to the testing and training. So I'm going to be asking you, how do you prioritize which ones you're going to go look at first? Because it's going to matter how you deal with these things. We're going to look at a couple other parts and pieces as we take these total number of 4,584 citations that were issued in that first 6 months. Now, this is actually ranked by state. And so you can see California is far and away above everybody else. And then we sort down through them, and you can see the top 10 of all those states, that's 70% of the tags. And if you go to the top 14, which actually is the total, those with at least triple digits in the citations, 82% came out of that the 14 facilities. And when you think about it, boy, there's some focus in some of those areas. Well, I want to look at another focus, all right? And it's scope and severity. Which tags, or which scope and severity level were used the most? And you can see that it was the C's, okay? Of the 4,500, 3,300 came from, fell into scope and severity of a level C. You can see drop down to the highest level that was cited, and it was an F. And that's really kind of a big number. That's a lot, especially for the first year. Well, when you think about it, I can see why, and I honestly believe there's some verbal instructions given to the surveyors. I really, really do. And I'll bet you they were told no A's, because they wanted the communities to have to create plans of correction for everything that was issued. So there were no A's. And I was over in Oregon last week, along with Oklahoma, and in Oregon, and we're going to take a look at it, they were given verbal instructions that they were supposed to give all F's. All right. So here's what we find. So Oregon, the total number of F tags given for Oregon were the highest. That was 137 out of 141. All right? And it's because they were told when they did the surveys that they had to be at least level F. So there's some skewing in some of these responses. But the reality is they've issued an awful lot of citations, all right? So when I sorted it by description of the tag itself, now we can see a different kind of a focus. The EP plan is significant. There's a lot of information that needs to be included in that, and they took 107, which is the highest number out of the 782. That one tag had the most number of F tags in terms of scope and severity. So how are you going to determine where you're going to start on your redo? Because obviously you've got stuff in place. You've been working on it. You've got good programs, and if they're not right where you want it, that's fine. It's like I've shared with lots of other people. Fix them, and it takes time, and it takes work and cooperation. If you're a one-man band trying to implement this, you have my sympathy, because I don't think it's a one-man or one-woman kind of an undertaking. So if we were in a class, I'd actually ask you, what are your predictions? What's going to happen during the second half of 2018? What's going to happen during 2019? Well, here's a quote from one of the surveyors. We're going easy with scope and severity this year. Next year, we'll be issuing IJs. As crazy as that might sound, that was the warning, and we heard it from more than just the one, and you'll see some of these quotes as we go forward. So how are you going to determine where to start? I think you got to have policies and procedures in place. I think you got to make sure you're doing your training. You've got to make sure that that the people know what you're doing and what you're thinking and the journey that they've walked on. And when we talk about the journey, how are you going to share your journey? Who are you going to share it with? Let's take a look at that. Okay. So keep in mind, when that surveyor walks in, this is still pretty doggone new for them. It's new for the staff, too. You got to give them a chance to learn these things. And the only way to do that is to repeat it to them. Make sure they get it. Make sure they understand it. We'll push this idea a little bit further here in in a couple more slides. And think about it. In the past, trouble starts when somebody, and that's going to be the staff on the floor when the surveyors are there, they can't answer a question or they can't satisfy the request. Just think about that. How can you better prepare them? Remember that if you've had an EP plan, emergency preparedness plan in place, which you have for a long time, you've got policies, procedures, and practices and processes in place, and they're probably pretty doggone good. They carried you a long way. And I would just suggest to you that when you think about the training and testing, you might want to devote some of those resources to helping the staff become more familiar with the plan contents. What kind of changes have you made? Where is it kept? Who's got responsibilities? You may even want to do little pop quizzes with the staff as you're walking through, as you're rounding, as you're visiting with folks. And there's nothing wrong with getting some of those mini Snickers bars. So how are the surveyors going to respond? They have been given specific instructions for different tags to do some of these kinds of things. Okay, ask to review. Review what? Take a look at your EP plan. They want to see it. They want to know where it's stored. And the staff ought to know where it's being kept. If you have nursing stations, you're probably going to keep them at the nursing station. Keep it in the front office. Keep it in the DON's office, the administrator's office. But make sure the staff knows that too. They're going to ask to see evidence that you've got your logs, that you're doing your tests, that you're doing your checks. And when you look through that list, you look at that last one and you think, what the heck is an AAR? I hope that's an acronym that's more familiar to you when we're done with this, because that is an after action report. All right, there's lots of them out there. It's not something you need to go buy. There's one in TELS. They're all over the place. CMS provided one, but it's like 17 pages long, which, good grief, you got to be kidding me. A single page after action report done well. And you ought to use that even after drills or after a real event or when you participate on a phone call with somebody where you're talking about these kinds of things. Maybe you're doing a collaborative effort with a local nursing home. Start your after-action report right away. Use it as your document for the fact what you learned, what you're going to do, what you're going to do differently. And they might ask the staff, show me. Show me what? Show me if you lose power and the generator doesn't kick in. What about the residents on the memory care unit? It's a locked unit. What are you going to do about that? Or show me what you would do if somebody pulled the fire alarm. Show me what you would do if you pulled the fire alarm. You're going to do interviews, not just with management. They're with the management team. They want you to do them with residents and families and frontline staff and everybody else. Get them used to some of those kinds of things. And we're even going to talk about creating a one-page snapshot for your residents and families. Why not? Put it all on a single page. They know what it is. You can talk about it. You can talk about it in resident meetings. You can talk about it with residents and families and make sure that they have a good sense as to what's going on. Talk about with everybody what kind of changes you've actually made. Maybe you do your fire drills differently. Maybe you've changed how you are going to meet after, when an event has occurred. Where are you going to meet together so that they can get assignments, so that they know what they're going to go do, helping who. And number 6, make sure you've managed your communication plan has a variety of different parts and pieces in it, including how you communicate with your residents. You got to be covering those 5 Ys, okay? Or 5 Ws. There's nothing new there. Nothing new there. That's the kind of stuff that we should have been thinking about all along. And there you go. For sitting through this so far, I give you at least a picture of a Snickers bar. You can actually get those little minis too, much smaller, a lot less expensive, but they sure taste good. All right, so let's talk about Now, one pager for your residents and their families. And when I was working on this slide, I thought, why don't we call it We Care Emergency Plan? So I get it. Okay, so it's hokey, it's corny, but it communicates a good thought to the residents and to their families too. We're doing this because we care about you. What are we doing? Why are we doing it? Well, we love and we care about you. We want to know that you know, and we want to know that you know how to help us, what your part is. What is the emergency plan? Well, it's based on 4 pillars. And list the pillars. We just looked at them ourselves. And here's how you can help us. I keep pushing the wrong button, guys. That's my fault. It's nobody else but me. And who's involved? Staff, fire department, your emergency preparedness office, sheriff's department, all of those different folks. And your ombudsman should be involved too. There's actually a checklist out there that lists what they should be doing. And it's probably 10 years old. It's been in existence, but you don't see a whole lot of involvement with them. And when we think about when we're going to talk to the family about this, it's also during the event. And you just tell them, look, we can call, we can post things, we can email, we can send text. What's best for you? What's the best form of communication for you? Clarify those sorts of parts and pieces. Let's talk a little bit about the question, because it's come up a lot. Do residents have to participate in exercises? All right, well, so I went through the different documents. Appendix Z, some of the Q&A, some of the requirements themselves. The Appendix Z are the interpretive guidelines. And page 13, in Appendix Z, residents are made aware of procedures to evacuate. So they got to know in advance. ETAG 0035, method for sharing emergency preparedness plan info. Residents, families, or their representatives. Page 51. It's a recommendation that they make, and I have learned that, when the federal government recommends that you do something, I think it's a whole lot more than just a recommendation, that you actually provide them with this family fact sheet, okay? So what are the survey procedures going to be like? They're going to verify that the communication plan contains this. They're going to ask the staff to share. How are you sharing this plan with the residents? They're going to do interviews with residents and families. And then that checklist that I mentioned. All right, so we're going to shift gears a little bit. What experiences have you had? I wish we were in a room full of you instead of a webinar, because I'm interested in what your experiences have been. But I was able to reach out to a bunch of the folks from the from the Loss Prevention Forum and ask for some of their experiences. What have you learned from the surveys that you've been through? Talk about the assessment form first. The HVA, hazard vulnerability analysis, there's all different kinds of names for it. Even the interpretive guidelines do not specify a plan. All hazards vulnerability risk analysis, whatever you want to call it, whatever you do call it. But this group, this corporation, had adapted an HVA from California. It's, and we'll take a look at this one because it's very thorough, very complete, very long. But also, it's doggone good, too. But it's not the only one that's out there, and others do a good job as well. And they actually did some modification to it, specific hazards. They eliminated some things. They added some things. They wanted it simple, but they wanted it quick to complete. Now, let's talk about the complete. It's important that when it says review and update annually, we're talking about this survey, too, this hazard vulnerability analysis piece, too. You can't figure you did it. Well, I did it in 2017, so I'm good for 5 years. You got to update that thing, too. And it's sort of like when you make a change in the community. Let's say somebody adds a chemical plant down the road. Or you learn that, those tankers on the freeway are carrying something you didn't know they were carrying. Or you got a railroad spur not too far away. So you need to make sure that at that point, that's a significant change. It's just like a change of condition for a resident. It's a change of condition in your environment, your local area. You need to make a change in your plan, too. And then they really focused on the top 5 hazards in their hazard vulnerability analysis. And I think it's a good approach. It's not the only approach, though. You take a look. If frequency or severity of the 6, 7, and 8 are fairly high, obviously you need to address those as well. And what they're finding is if you can show that you're consistent in your application of the policies and procedures and the practices that you've outlined in your plan, you're going to do well. you're going to do well. Let's talk about elopement. There's some confusion on that. I think it's confusion because we've got surveyors out there that think elopement should be as high as things like hurricanes and tornadoes. And yes, loss of life in any number is unacceptable, but a hurricane, a tornado, a severe winter storm, those kinds of things, there is a higher severity on those. Elopement has to be dealt with, though. And so that was just the reflections that this care provider actually talked about and sent back in to me. A little bit about surveyors. They've got a wide range of perspectives, different levels of scrutiny on different specific requirements. And the reality is the fact that some are more, they've stepped a little bit out of the enforcement, and they're trying to do some teaching with us as well. And I think the really good ones are going to be learning from you as well. You know a lot. You know a lot. I'm not the expert on this phone call. You guys are the experts. You do this every single day. We had a Kansas surveyor that got bent out of shape. Why? Because in Kansas, they were using an HVA, and they left the hurricane in there. Well, they had valued it as 0, so what's the big deal? Well, you may as well know what the surveyors want, and then try to make sure that you're going to meet them appropriately. And then, there's just an explanation of how they handled it. Surveyors' questions, and they don't seem like they're all that difficult, okay? Did you change your EP plan since the new requirements went into effect? And it could be simple things. It could be, who's going to actually conduct the fire drills. I mean, in all fairness, it doesn't have to be just maintenance. Quite honestly, if you let some frontline staff start participating, that can be a really good thing for them and for the community. And then, they want to see the plans. And that's low-hanging fruit. Make sure that you've got those accessible. And the mere fact that you have it electronically, make sure it's printed out too. Because all you have is paper, all you have is electronic, they will ask you about it, and they can potentially cite you for it as well, just because you're required to make it available. And it has to be available on all shifts. So if it's in an office that's locked during the night, that's not going to meet it either. Yeah, we're seeing some back and forth between different venues. Nebraska, they want to see evidence of collaboration. We're going to touch on that one in a significant way here in just a few minutes, okay? They want you to have sign-in sheets. They want you to show minutes, those kinds of approaches. And the Maine Fire Marshal is the one that warned us about the IJs. We continue the inconsistencies. Iowa, they weren't necessarily thrilled with the idea of a corporate customized template. So be careful with that. Make sure that when you get it, you can show your own customizations as well, okay? And we had somebody, and I think that this is kind of like when we talk about volunteers. I think there's some learning that needs to be done about levels of communication, because they said that you should replace cell phones with handheld radios. I think they're two very different instruments, two different, very, very different kinds of communication. And so we need to be careful that we're able to meet the communication requirements that we spell out in our plans. But always look, whenever you're looking at technology, affordability, capability, those things need to be compared. We see a lot of variety between who's actually doing the surveys, okay? Health surveyors, fire marshals, it just depends. And they refer to this CMS worksheet that's out there. And so again, through Sue Levin, who's helped me a lot on these presentations, she helped me find a copy of this thing, okay? And this is the lead-in page, top of the first page. Nothing surprising there. And then they just go down through the E-tags. And they don't include interpretation on this. They merely include the standard itself. So the interpretation has come from the mind of the surveyor, but you want to try to be sure that you can talk about your journey. We started out there. Let them know why you're doing what you're doing, how you made the decisions. And if we just flip through the various pages on this thing. All right? Now, I'm going to pop this one more click, and you're going to see a bunch of orange stuff here. And it's actually talking about if the long-term care facility decides to be part of the integrated healthcare system. Healthcare facilities that elects, long-term care facilities may choose to participate. Well, if you decide to participate in these things, then you have those 5 requirements. But there is an if there. Well, I just got this with some help through Sue, and this is sort of, for me, news. I've never used that kind of a lead-in before with all the flashy stuff and the increasing font size and that. But for me, this is the first time. I started healthcare in 1981. This is the first time that I've ever seen the federal government take anything back to try to reduce it, to make it less burdensome in our long-term care industry. I think this matters, and there'll be 3 or 4 that they actually made changes to. So on the 20th of September, which obviously is just a few days ago, they published a proposed rule, all right? And so it's still got a process to go through. They have to, I think it's for 6 months, they've got to gather comments, and then they have to respond to the comments, and then they need to do their final decisions. But this would help you be able to devote your resources to improving care. They're going to reduce some things. They're going to extend a period of time for you. So I think that these really make a difference. There's 3 categories of changes that they've used. They're going to simplify, streamline processes. They're going to reduce the frequency of activities and revise the timelines. And they've done some removal of some parts and pieces. And there was some, even though it was a new law, there was still some of the parts were already obsolete. And you can see this is 2 of 2. This is second and only slide that we're going to have dealing with this news flash. The proposed rule impacts these SNF emergency preparedness provisions. Eliminates documentation requirement of the collaboration cooperative efforts that you have with your integrated healthcare system. You don't have to document that anymore. Now, keep in mind, this is a proposed rule. It's not there yet. They may still want to tag you for that because this proposed rule hasn't kicked in gear yet, nor will it until it's actually accepted as a final rule. So at this point, when it comes down to your cooperation, collaboration, participation with the healthcare community, I have to use after-action reports for that. It's a darn good tool, and it's available to you, okay? The second one is they reduced some annual timelines to biennial timelines every 2 years instead of annually. And that's on your training and your retraining. You do your initial training, and that's good for 2 years now instead of 1 year. But also, it says every one of the e-tags says that you should review and update at least annually. They've proposed that that's every 2 years now. And then it redefines testing exercises, which I think is a big deal for us, okay? In order to fulfill the requirements, and it'll be your choice which of these you use. For one of those, okay, it'll be community-based full-scale exercises, no surprise. Or you can use a facility-based functional exercise. Or, and quite honestly, a functional exercise really pushes you over more towards a drill, okay? And then they say a drill, but they also say a tabletop or a workshop, but it has to have a facilitated discussion so that you can actually include and involve everybody that's on the team. So those are big changes for us, but they're not final. But I just wanted you to know about them. We just got a hold of them today. So if you do choose to participate in those same healthcare coalitions that we hope you're going to be able to reduce your documentation of, how do you show it? By participating in it, you can demonstrate intent to comply. And not all of your healthcare communities are going to be equal. Some are very, very long-term hospital-focused. Some are more welcoming to the long-term care. All right. Survey results, vetting and training of volunteers. This is an interesting one. I'm not sure that they understand the long-term care use of volunteers. So when we think about volunteers in our world, we're thinking about volunteers that are going to come to us from our local community for the most part. But there are other kinds of volunteers, and the Texas survey, I think, was confused on this. He said, how would you vet and provide appropriate training for a volunteer fire department? I don't think that standard's really talking about volunteer fire departments. It's just like this one. If you get volunteers through FEMA or the Red Cross, they're asking the same sort of a question. How are you going to verify that they are who they say they are? And I just like this remark that the care provider shared with me, the fact that this surveyor was a real pain. Oh, man, that felt good to even say that to you. Okay, I hope I don't have any surveyors on the phone with us. Training exercises. Let's look at survey results just one more time. That should be one of your biggest focuses for 18 and 19 because they're coming for you. Remember the total number of citations per tag? There's the 3 tags. It was twice what they were on all the rest of them. Big deal. And the response that this corporation had was the fact that they've created training templates and quizzes for each department. Now, on these responsibilities, it's not their day-to-day responsibilities. It's their when you're in an emergency situation, whether you've sheltered in place or you're evacuating. And again, it's going to be the big focus. And here we go again. More surveyors have said the same sort of thing. We're not tagging them too hard now, but we are going to come get you next year. So how are surveyors trained? And you can actually go out and take a look at the training. You can actually sit through it. Don't sit through it in a comfortable chair with the lights dimmed and a full belly. Trust me, you'll go to sleep. I went through this stuff. It's not overly exciting. I want to do a quick sidebar here because they talk about, in all of their training, they talk about policies, procedures, and operating guidelines. And I wanted to give you examples of it, okay, of each one of these. A policy, it is the policy of your facility to have defined procedures to protect the life and safety of both residents and staff should there be a hazard that causes the healthcare facilities to decide either to shelter in place or evacuate. That's a policy. There's no how to do it, but it's what they're going to do. The procedure. Now we're going to start getting into not just the what we're going to do, but how are we going to accomplish it. All right, so this procedure, after receiving the directive to evacuate, all available staff will report to the designated personnel staging area. The ops chief, which is a title that you would pick up from your FEMA training, and it's worth going out and taking a look at the healthcare training that's available to you out there too, okay? You may as well get used to it. You may as well get some of it done. Not everybody on the phone needs to do it, but somebody in each community should be doing it. Okay, so these are this is an example of a checklist, a guide, an operating directive that should be part of your policies and procedures, okay? And in 3 cheers for Dane County down in Florida. That's where I found this one. And I think it's really good. They call it START triage. And START stands for Simple Triage and Rapid Treatment. And you can see they use different color tags based on the assessed status of the resident in this particular situation. And you can see green, they're ambulatory. You can give them verbal directions, they can follow the directions, and they can help in their own evacuation. Then we get into the yellow. Sometimes residents' care is going to have to be delayed a little bit. They're healthy enough, it's not an emergency. Then we get to red, and that's immediate care needs to be delivered. And the black, that's already deceased. So good tools to have, good way to help to identify the residents so that at a glance, without having to read anything, you know what their status is. Let's talk about the program itself, policies and procedures. And this is just sort of a little decision tree, if you would. Where are you in this process? Okay, you're going to have to do your assessments, your hazard vulnerability assessment, and then you're going to have some procedures, policies and procedures on how to actually do that. And from that, you're gonna dig into your 6 requirements, and especially the 4 core requirements, and you're gonna have to create the policies and procedures and the necessary guidelines so that you can deliver in all those areas. And we're gonna talk about continuity of operations. An example of continuity of operations is if you have somebody and if you're evacuating or you're sheltering in place and they have needs for dialysis. You're going to need to make sure that you have that built into the plan. That might be specific, resident specific. I doubt that it's a general condition for all of your residents, but you need to make sure that it's in there. The communications plan is a big deal. It's no longer just the 4 levels of communication that the communication tools that you're going to use. It's also what you're going to communicate to who, how, and when, and how often. All of those pieces need to be in there. And then the training and testing program itself. And that's for all aspects of your training and your testing. Let's talk a little bit about specific policies that are spelled out in great detail. Those 11, I also added collaboration. Okay? We're going to look at a couple of them. In fact, you can see subsistence needs, shelter in place, and number 11, facility waiver policy, 1135 waivers. What happens when there is a waiver? And you can see those, and then a little bit about collaboration. The asterisk just reminds this old man that we got to do that. Here's a question for you. Is this compliance or non-compliance? Survey asked the DON. So have they designated who will take your place if you're not available when an emergency is declared? Her response, you know what, we don't have many emergencies around here, so they just gave me a dedicated mobile phone, and they'll just call me if they need me. Compliance or non-compliance? Answer, it's non-compliance. Okay, because you need to have succession planning and you need to have delegation of authority. It's just like, don't think that your emergencies are going to happen during a day shift and you're fully staffed and whole management team. It's probably going to be most of them evening or night shift when the staffing is a little bit different than a day shift. Well, as more people are called back into the facility, you're going to have to do the same thing because your charge nurse is probably going to be in charge of much of what goes on. Well, what's the succession? As the DON, as the ED, as other folks start coming into the building, you need to have a written plan as to how you're going to pass that authority on, and as well as the responsibilities. So make sure that that's part of your plan. And I'd have you ask yourselves, which ones have you actually delegated authority for? Because I would think security would be one of those things that you really want to make sure that you've got a defined policy on how you're going to handle security, access to the community once the doors are locked. Question number 2, true or false? Your EP plan must include a process for cooperating, collaborating with local and tribal, regional, state, and federal EP officials. Now, don't think because they've changed the documentation that the requirement has gone away. This is a true statement, and it's still true. Okay? And what have you set up in your plan to guide and direct and explain to outside agencies how you're going to cooperate and collaborate with your local healthcare community? Question 3, true or false? CMS is silent relative to where you keep your emergency preparedness program. Well, you know what? It's not silent. You've got to keep it in places where it's accessible by your staff, that they know where to go. You could even put a sign up saying EP, Emergency Preparedness Program binder stored here, or it could be red. And you know how you've seen them red, 3-inch binders with large font down the back spine, EP plan, those kinds of things. So it's very evident when you walk through. And I'll tell you what, you asking you where it's stored isn't what's going to matter. You asking your staff where it's stored, they're the ones that need to have those answers. Multiple question. When assessing for compliance with the general requirements for policies, procedures, and standards, surveyors should review EP plans to verify that policies and procedures addressed and were developed, I'm reading the question because they're going to read it to you too, in accordance with the risk assessment and what part of the plan. What deals with communications? Okay, I just gave it away. It's a communications plan. Okay? These things, how you're going to communicate, who you're going to communicate to, even like your ability to receive overflow capacity from the hospitals. Think about Las Vegas when we had that mass shooting. Think about the hospitals. Had their emergency rooms were overwhelmed. All right? And you need to be part of that. You need to let them know which kind of patients you can take and for how long and what equipment they would need to send with you. True or false? Community-based risk assessments, community-based, that means not just looking at your assessment, but you're actually working with other care providers, with other agencies, and taking a look at their risk assessments. They may know about stuff on your freeways you don't know about, or on your railroads, or other plants. Think about that chemical plant a few years ago down in Texas. 20 miles away, and that nursing home had to evacuate. Do you know how many residents they lost? None. Think about that. They were prepared. They were prepared. You need to be prepared too, and that's not me being nasty. Just, my goodness, if it's, people's loved ones are there, and you know that, and your staff is there. Take care of them. All right? Community-based risk assessments. Become familiar with that. And then there's just 3 pieces that I'm just going to go on one slide. Each provider will have its EP regulations incorporated into the requirements for certification. Needs to be part of your requirements for certification for your Medicare. EP plan activation, like there's a real flood, there's a real snowstorm, there's a loss of power, the grid goes down, any of those kinds of things. It does fulfill the requirement for one of your individual or your community-based exercises for the year. You're still going to have your second exercise, though. Surveyor training is available to providers. Yep, it is available, and it's something, there's a link down at the bottom of this page. When you get this, you can actually go out and you can find it on the CMS guidelines as well. Go take a look at it. I already said it's not exciting, but I'll tell you what, it would be good for you to know at least some of what the surveyors have been trained in. Another thing to keep in mind, okay? Yes, they're going to change it. Hopefully that proposed rule that changes your review and update at least annually, hopefully it'll be changed to biannually, but don't think it stops there, because let's say you made a significant change. Maybe you opened up a wing for, maybe it's for those residents who require tube feeding. All right, maybe you're going to add a dementia care wing on. Any of those kinds of things, you've changed the exposures, you're going to need to show that you've already, before the 2 years or the 1 year is up, that you've already reviewed and updated your plan to make sure that you've given due consideration for those requirements. All right? Put in logs, have signatures, and you can find in interpretive guidelines that on this review, it's not just supposed to be an operations review, but it should be a clinical review as well. So have 2 signatures on your logs. All hazard risk assessment. All hazards. Is it just your community? Just your residents and staff? No, it goes beyond your property line, goes beyond just your neighborhood. It might even be beyond a region, be beyond a region in the county. It could get into your entire state. I mean, we've had a couple of states. I listened to that one news story when we had those hurricanes that came in. That one area got 62 inches of rain. I don't care how hilly or how flat you're going to have water like you never had before. All right? But it even goes beyond the states. Okay? It could be national. It could be the entire country. If we lose the grid countrywide, what a mess. Think of global changes too. All right? So your hazard vulnerability analysis, yes, it starts close to home, but it's expansive. It's in its considerations. And, there's all different kinds of them out there. There's different versions. I've got a whole bunch of slides in here of different versions that I've hidden just for lack of time. With 60 minutes, we're kind of limited. But you don't want to limit yourself on the emergencies that you consider. Here's one, and this is in the TELS program. Take a look at it. It's a good, solid, simple, straightforward, documented, easy to use, easy to access hazard vulnerability analysis. Here's the one from Kaiser Permanente, that California one that I had talked about earlier. All right? Very thorough, very complete. And it probably has a whole lot more things than you're going to think about. But it's a good tool, and if you've been using it, again, I'll repeat it, you got to keep using the tool. The fact that you did it in 2017 doesn't give you credit for any other year in the future. You need to continue to do hazard vulnerability analysis. And you know what? I put the slide in there. This is from Harvey. And actually, I had pictures of the roof that was torn off of this nursing home. And just think about that. What a mess. What a mess. Life-changing. I don't think they ever opened this facility, but this community up again. And I don't care how well you plan. I don't care how good you execute. There can still be losses like this. The one that you've got to focus on is prevent the loss of life. Okay? And take great comfort from the fact that you've done your best. Okay, 3 more pieces: waivers and subsistence and volunteers. All right, this is a stinky diaper slide. And I've never used this before, but I like that watermark. Okay, why? Because there are, I don't know how many, it's 231 words in this one slide. See that little number down in the bottom corner? That is way too many words for one slide, but I want you to know this information. I want you to have it in a written form, okay? This is talking about alternate care sites. And this has have to be a shared discussion with other healthcare providers in your area. You need a policy. Waiver procedures. What happens when there is an 1135 waiver? We're going to talk in detail about it, about how it actually is issued. But once you've understood how it's issued, then I want you to come back to this slide and see those steps. You see the 1 through 5 steps? They're blue. You need to make sure you have this built into your policies and procedures. And then volunteer procedures. There's already plenty of confusion as to what is a volunteer. All right, good words. I'm not going to read them to you. You're smarter than I am. You'll understand them better than if I chew them apart for you. So you go ahead and you read them, get back to this slide, and know that you've got 3 really good references here. These are quotes from different documents. All right, let's talk about the 1135 waiver. What is it? It's a lifesaver for you because there are times in various emergencies, it's such a moment of exigency, you won't have all of the information you have about a given resident and all different kinds of things, all right? But you still need the supplies and the services, and that's one of the efforts that this is intended to help provide. Because, again, you're not going to have all of the information, but you're going to have to know in advance of. You're going to have a policy on 1135s. If you reach out to your local association, whichever association you belong to, they work on these things. They have good information for you. That's probably where you'll receive your first notice, though I have seen that the federal government is becoming much, much more aggressive in sending these things out. Think about the hurricanes that we've been through. Even last year, a lot of information was dumped out around there. So what has to happen is the president declares a major emergency, the health secretary declares a public health emergency, and then the Health and Human Services secretary grants an 1135 waiver. All right? And it's all based on federal requirements. There's plenty of laws. You see 2 of them mentioned up under the first. It's the second line on this slide. So what kind of things can they waive? You can use out-of-network providers. That EMTALA, that's a law that was passed several years ago that prevents hospitals from dumping someone before they can, in the emergency room, to another facility, to another hospital, before they stabilize them. Well, in certain emergencies, again, like Las Vegas, or some of these massive hits by these unbelievable the weather that we've had, the hospitals have agreements in place so that they're going to send specific kinds of potential patients to other facilities before they've been stabilized so that they can be stabilized because they are being overwhelmed. Licensure issues. If you have to evacuate outside of your state, your CNAs are suddenly without license. That can all be waived. You can see a couple other ones. And then think about it. Whether you're evacuating residents or you're receiving residents, there's times you just don't have what you need in order to make sure that you're going to get paid. Well, know that an 1135 waiver is issued time sensitive, when it starts, when it ends. And you also have to demonstrate that you knew about it. And so you need to have a policy and a procedure. You need to have somebody responsible to keep track of these sorts of things, especially whenever there's a potential for a declared emergency. Subsistence needs. What are we talking about subsistence? Those minimum pieces that are required to keep us alive. Keep who alive? Not just your residents, okay, but your staff, volunteers. You may even, it may be a severe enough emergency that they're going to bring their families with them. All right, so when we talk about food and temperature maintenance and those kinds of things, that's the subsistence needs that are required, okay? And that's whether you shelter in place or you evacuate. If you're going to evacuate to another site, you got to be able to show that you have due consideration for all those possibilities. And it's hard. There's a lot of guesswork involved in this, but not really, because you're experienced, you're knowledgeable, you're intelligent, you've got institutional knowledge, you've got area knowledge, and that's what you use to build your plans. You can see the stuff that they want you to have. You know, when you think about the safe and sanitary storage of those provisions, there's a community I talked to a year ago And they said that what they do is they have a contract that brings, that a water company will bring a 3,000-gallon tank and park it right there on the lot whenever there's going to be an emergency that may challenge their water supply. That way they can flush their toilets. Even if it's bucketed water, they can still flush their toilets. Okay? On the temperatures, you don't have to try to maintain the temperature throughout the entire community. You can do it in specific, defined areas, larger spaces, and then you're just going to start shutting things down. A good friend of mine had to do that in Texas when she was the administrator at a community, and she ended up having to bring in air conditioners because Texas gets hot. And what they did was they actually piped the air conditioning into the ductwork through an exhaust through one of the outlets, and then they just pushed it through, and they restricted the flow into the areas where they were going to keep the residents. So there's lots of things you can think of. You're creative, you're intelligent, all right? These are the things that matter. Think about it, because you're good decision makers too. Encourage volunteers. You got to have them, okay? They're going to come to you with whatever skills they bring. Sometimes just being able to be there to help, comfort, support, carry, load, that sort of stuff is really, really important. Where there's shelter in place, you got to have that policy. All right? Now, it isn't saying that non-nurses can do clinical care. Not at all. Okay? It's still credentialing matters. Non-medical, non-credentialed volunteers do non-medical, non-credential requiring tasks. It's okay. There's still plenty of space for them to do things. Okay, your state laws still matter. Okay, your facility policies still matter. So if you have a policy that says such and so, and you know that there's a chance that in a given emergency that you might not be able to keep that one, you need to have the additional policy relieving you of the burden of that policy that you can no longer keep. Pre-event, make sure you become integrated in your volunteer registries, in your state-based emergency systems, even reaching out to your local emergency preparedness offices. Become part of them. And here's just a quick thought for you. Use this at scout camp. Been to scout camp so many times, you think I wouldn't go back, but I still keep going back. I've been a scoutmaster 3 times, and by the way, for anybody that cares, our 3 sons are all Eagles. Whenever for one of the first things you do now, whenever you go into a scout camp, is that they give you this band. And it's a specific color, and it has their identification information on it. So the reality is, if you see somebody on that campus, in that camp, without this, you know that they probably shouldn't be there. Okay? So that is exactly what we were going to go through. All that stuff right there, we ended with the volunteers. I certainly appreciate you attending. Guess what, Savannah? It's your turn, ma'am.
Thanks so much for that great presentation, Ray. Our first question is, can you please clarify if this is primarily for skilled nursing or assisted living facilities?
That is the question of questions, isn't it? The reality is that it's Medicare participating, certified care providers. Okay? Now, here's the challenge I have with this thing. It's just a plain and simple fact that if you're on a large campus and you've got some of both, You've got assisted living. You've got skilled level. Are you going to have 2 different plans? That's a decision you're going to have to make, because that would be very, very difficult to pull off. But these regulations, in and of themselves, apply to those really to the skilled side. Good question.
And then, can you please just clarify one more time where you got this data from?
Sure, it's right out of the federal CMS's website. It's the data that they collect, that they use to do the analysis. There aren't a lot of folks out there yet doing the analysis. I know that American Healthcare Association Emergency Preparedness is planning on doing that, and the quality of assessments that evaluations that they do. So that's where it came from. It wasn't stuff that we extracted in and of by ourselves.
All right, and then when you talk about collaborating, how do you get that started? The hospitals won't even talk to us.
That's nationwide, folks. Nationwide. There's a few pockets where it's different. And so for right now, it's text them, email them, invite them to lunch, invite them whenever you're going to do, well, what's the next holiday? Thanksgiving?
Yes.
Yeah, Thanksgiving is the next holiday. You're going to have some sort of a Thanksgiving celebration. Invite somebody from your local hospital to come over, meet your residents. What happens when people meet your residents? They fall in love with them. they're more willing to participate then. Also, make sure that they understand that, when it comes down to that capacity that they're going to need where they can transfer some patients to, when they become overwhelmed, let them know how many beds you have, because you can do things for them that they can't do for themselves. That makes you valuable, but you got to communicate. That's part of your journey. You need to communicate. Good question. Whoever wrote it, you're thinking.
All right, that is all the time we have for questions today. If we did not get to your questions live, we will email you the responses. And now for anyone interested in hearing about our emergency preparation products that Direct Supply offers, please welcome Karl Seagren.
Thank you, Savannah, and thank you, Ray, for the excellent presentation. My name is Karl Seagren, and I am the product consultant with our environmental products here at Direct Supply. With over 1 million products in our offering, Direct Supply does have the broadest selection in senior living. This includes all the essential items that you'll need in the event of an emergency from popular brands like Rubbermaid, Clorox, Motorola, Lysol, Duracell, you name it. We've got it. And we do realize that many of our customers may have a source for these products, for these emergency preparedness products. And for those of you that do not, know that you can come to Direct Supply for all the products, all the key items that you will need. We actually have put together an emergency preparedness product guide, which will be emailed out to everyone following the conclusion of the presentation. Most of these products do ship out for free and will be delivered within 1 to 2 business days as well, so you won't have to wait very long. If you do not receive this copy of the email or in the guide, please reach out to your account manager. And then, given the recency of Hurricane Florence, we also wanted to highlight some products that each community should have in the event of a hurricane. So in addition to all the essential items noted on the last slide, products like air movers, dehumidifiers, wet dry vacuums, window protection, rain suits, these types of things are all available and critical items that you should have to help you react to and recover from a hurricane.
Great, thanks, Karl. And now please welcome our TELS trainer, Dave Race, to show you some of the emergency preparation tools and other great resources that are available on the TELS platform.
Thank you very much, Savannah, and thank you, Karl, and special thanks to Ray for all that great information. It was a lot of information to take in a short amount of time, and with the CMS code, especially in this area, it can be very ambiguous and hard to know really just where to get started. So what TELS has done is we've created 4 best practice tasks that you can add to your schedule so that you can actually take action on these items to not only make sure that you have your program in place, that you have your written documents stored, but that you're doing your training and your testing, and that you're documenting all of that information as well. So I'm just going to take you through a very quick tutorial on the TELS platform itself, and we'll take a look at these 4 tasks in a little bit more detail. I've got them loaded up here. I use Task Self-Service to load these to my task schedule. And the first task that we're just going to take a very quick look at is developing your emergency preparedness program, and this is your overall program. Remember when Ray said that the surveyors are going to go a little bit light in the beginning, but they will be looking for this information. So you need to make sure, I know many of you may already have a program in place, you need to make sure that you take a real good look at your program, make sure that it's going to work, and make sure that you're updating it at least annually, or as Ray said, at least every 2 years. But for right now, you want to make sure that you get that updated and stored, and you can do that right in the TELS program. So when you're developing your overall preparedness program, especially if you're not sure where to get started, this task is going to help you immensely. We have some resources here. We have an E-tag overview. So we actually take all of the E-tags and explain in layman's language what each of those means. So that's a great document and a great resource. And then we have our emergency preparedness self-assessment. So this is really going to help you put together your overall program, give you some real specific action items that you can take. And then also, of course, we have our set of comprehensive instructions. You can see these are pretty lengthy, and this is really going to help you make sure that your program is headed in the right direction and make sure that you're getting all the elements in your program that you need. And then, of course, we have a document storage section in the TELS platform where you're actually going to save all of those documents that you're putting together for your program. The second task that I want to show you is to actually conduct your facility assessment or your risk assessment using the all hazards risk approach. So I'm just going to pull up this task really quick. We actually have a document that we've created. I know Ray showed it to you quickly on the screen earlier. I'll show it to you a little bit more in depth. In addition to the instructions, we've also got the ETAG overview and the self-assessment here. For this task, you're going to want to take the actual hazard and vulnerability risk assessment using this tool. And this is a tool in Excel, so it's going to automatically score it for you. And what it'll lay out, you'll see here, the first page is going to give you some instructions. So you want to make sure that you read through these instructions. It's going to really guide you through the process. Then you're going to actually get into the tool. So you're going to look at some of the hazards that are in proximity to your facility and what potential hazard that would be to your facility. So you want to make sure you go through each of these and score it for each one. And then we've got the actual hazard and vulnerability assessment tool, where you're going to determine the probability of an event occurring, the risk to your community, your residents, your staff, and then how prepared you are for that particular event. Enter all of that information in. It is an Excel document, so it will automatically score it for you, and it's going to give you, at the bottom, your top 5. And these are the top 5 elements that you're going to want to make sure are included in your plan when you're putting together your actual plan. And we'll go back to the TELS program. So once you've completed your risk assessment, you want to then upload that into the document section of TELS. That way, when it comes up for the next time, it's going to be available to you. You're going to be able to download that and work off of your previous document. The next task that we're going to take a quick look at is your actual written plan task. So this is going to be your final product. You want to take those first 2 plans, those first 2 tasks, take action on those, and that is going to help you to develop your written emergency plan. Now, absolutely, as Ray indicated earlier, you're going to want to make sure that that plan is saved at the nurse's station. You're going to want to have a hard copy in the maintenance office, in the executive director's office. All of those things are imperative, but you want to make sure that you also save this master copy in the TELS platform. It'll be saved on the direct supply servers. It's going to be safe for you to download and print off whenever you're going to need that in the future. And of course, we have, again, our document section here. You're going to want to include not only your written plan, but any information that you get from other agencies, whether you're working with your local authorities, any local coalitions, if you do get those hospitals to work together with you, any information that you can gather from them, you want to save in this. You can scan them in, you can upload them to the document section in TELS. They're all going to be saved in there, and they're going to be safe for you to resource in the future. And then finally, the other task that we'll take a quick look at is the actual testing or the actual training itself. So there's 2 tasks that we've developed, our TELS best practice for those particular areas. One of them is going to be your full-scale disaster drill. As Ray was alluding to earlier, you got to make sure that you do your after-action report. And in TELS, we express that as a log. So you're going to be filling out that log for this particular task. You can use the one that's right in TELS. We spent a lot of time coming up with a really good log that's going to work in most instances. You want to make sure you have your signatures of everyone that participated in that drill. And of course, you can upload that all into your documents section. This is a very important task. This is the one that your inspector is definitely going to ask for at some time in the future. This is going to indicate to them how you are testing and training for those emergencies. So this is your actual disaster drill. You want to make sure that you're keeping all good records on that, and TELS is a great place to store that information and keep you on track. And then finally, you also have, for the tabletop exercise, a very similar task. We've got an after-action report for your tabletop exercise, as well as your document upload section for all of those documents that you get from whoever participated, whether they're signature sheets, information from your local authorities, your coalitions, other nursing homes that you're working with. You want to make sure that you upload all of that into TELS in one safe place so that you can access that information for the future. So We also have everything stored under our training tab as well. So whether you're using those best practice tasks on your task schedule coming up on a regular basis, you can also access this information at any time right here under the Emergency Preparedness Ruling section of the TELS training tab. It's all right there, including we are also going to be putting a copy of this webinar there as well, so you'll be able to watch it as many times as you need to, show it to your colleagues, even share it with other entities that you are working with, whether they're other nursing homes or the hospitals, for example, so you can all have that information in one place right under the TELS training tab. And of course, if you have any questions about this, all you need to do is just get back to TELS. You can contact us anytime if you have any questions about the TELS platform.
Thank you so much, Dave, for that great demonstration. And thank you again, Ray, for presenting our webinar content today. If you have any questions about the information or products discussed, please reach out to webinars@directsupply.com. For more information about our upcoming webinars, please visit directsupply.com/webinars. Once again, thank you for attending.